Welcome to this training on evaluation and management coding for personal injury and auto accident related visits. In this session, we will review how to choose the correct E&M code for office and outpatient visits, especially the codes commonly used in auto accident care: 99203, 99204, 99213, and 99214. As a provider myself, I understand how easy it can be to focus on the clinical side of care and overlook the importance of accurate coding. But proper E&M coding is part of responsible documentation. It helps protect the provider, supports the integrity of the organization, and reduces avoidable billing complications. This training is not about coding higher or lower. It is about coding accurately, consistently, and in a way that reflects the care actually provided. Accurate coding is important because the billed code must reflect the actual work performed and the medical necessity documented in the chart. In auto accident cases, visits can range from simple strain injuries to complex cases involving multiple body regions, imaging review, medication management, neurological symptoms, and referrals. The goal is not to automatically bill high or low. The goal is to bill accurately based on the patient's condition, the provider's decision-making, and the documentation. Coding should never be based on habit. One important reminder before we begin: CPT code 99201 was deleted and is no longer billable. For new patients, the current office and outpatient E&M codes are 99202 through 99205. For established patients, the codes are 99211 through 99215. So when we talk about low-level new patient visits, we begin with 99202, not 99201. Office and outpatient E&M levels are selected based on either medical decision-making or total provider time on the date of service. History and physical exam are still important, but they are no longer selected by counting old-style history and exam bullet points. Instead, the history and exam should be medically appropriate for the patient's condition. For auto accident visits, the documentation should clearly explain what happened, what the patient is experiencing, what was found on exam, what records or imaging were reviewed, and what treatment decisions were made. Now let's discuss medical decision-making, or MDM. Medical decision-making, or MDM, has three major parts. The first is the number and complexity of problems addressed. The second is the amount and complexity of data reviewed or analyzed. The third is the risk of complications, morbidity, or management decisions. For most E&M levels, the documentation should support at least two of these three elements. In auto accident care, this means the chart should clearly show the complexity of the injuries, what records or imaging were reviewed, and what level of risk was involved in the treatment plan. Be sure to understand the 2 out of 3 concept. In an auto accident setting, the problem element may include neck pain, back pain, headaches, shoulder pain, knee trauma, concussion symptoms, numbness, tingling, weakness, or radiculopathy. The data element may include reviewing X-rays, MRI reports, CT scans, emergency room records, prior treatment notes, or specialist records. The risk element may include prescription medication management, ordering advanced imaging, referring to a specialist, considering injections, work restrictions, or sending the patient for urgent or emergency evaluation. The more complex the problems, data, and risk, the more likely a higher E&M level may be supported. For new patients, the E&M codes range from 99202 through 99205. A 99202 is straightforward. A 99203 is low complexity. A 99204 is moderate complexity. A 99205 is high complexity. In auto accident care, the initial evaluation often requires more work than a simple follow-up because the provider may need to evaluate the accident mechanism, identify all injured body regions, review outside records, order imaging, prescribe medication, or create a treatment plan. But the code still depends on what is medically necessary and documented. A 99202 is appropriate for a straightforward new patient visit. In an auto accident case, this could be a patient with mild neck soreness after a low-speed collision, no neurological symptoms, no significant functional limitation, no imaging review, and simple conservative recommendations. The risk is minimal, the problem is uncomplicated, and the provider's decision-making is straightforward. This level should not be used if the patient has multiple injuries, worsening symptoms, significant functional loss, imaging review, prescription management, or more complex treatment decisions. A 99203 is commonly used for new auto accident patients with low complexity injuries. For example, a patient may present with neck and low back pain after a rear-end collision. The provider documents the accident history, performs a focused musculoskeletal and neurological exam, reviews basic imaging or decides imaging is not needed, and starts a conservative treatment plan. This may include therapy, home exercises, activity modification, over-the-counter medication, or a simple prescription when medically necessary. The key is that the condition is still uncomplicated and the risk remains low. A 99204 represents moderate medical decision-making. This may be appropriate for a new auto accident patient with multiple injured areas, such as neck pain, low back pain, headaches, and radiating pain into an arm or leg. The provider may review emergency room records, X-rays, MRI findings, or prior treatment records. There may be prescription medication management, referral to a specialist, ordering of additional diagnostic testing, or a more involved treatment plan. A 99204 requires documentation that clearly supports moderate complexity. It should not be selected simply because the visit took place after an accident. A 99205 is a high-complexity new patient visit. This should be reserved for serious or complex presentations. Examples may include significant neurological deficits, severe radicular symptoms, concussion concerns, extensive record review, complex imaging findings, urgent specialist referral, or high-risk management decisions. The documentation must clearly show why the visit required high-level decision-making. This is not simply a long visit or a patient with many complaints. The chart must support high complexity through the problems addressed, the data reviewed, and the risk involved. For established patients, the codes range from 99211 through 99214. In auto accident follow-up care, the most common codes are often 99213 and 99214. A 99213 generally reflects a stable or improving patient with low complexity decision-making. A 99214 reflects moderate complexity, such as worsening symptoms, new neurological complaints, imaging review, medication management, or treatment escalation. The difference between 99213 and 99214 is one of the most important distinctions for providers to understand.
A 99212 may be appropriate for a brief, straightforward follow-up visit. For example, the patient's symptoms are improving, there are no new complaints, no significant exam concerns, and the provider makes minimal changes to the treatment plan. The documentation should still support the visit, but the decision-making is simple and the risk is minimal. Reminder, not every follow-up supports 99213 or 99214.
A 99213 is commonly appropriate for routine auto accident follow-up visits. For example, the patient is improving with therapy, pain is decreasing, function is improving, and there are no new neurological symptoms. The provider may continue the current care plan, monitor progress, and document the patient's response to treatment. This is low-complexity decision-making. A 99213 should be supported by documentation showing the patient's current status, response to treatment, exam findings, and plan. Let's compare with 99214. A 99214 reflects moderate complexity. This may be appropriate when an established auto accident patient has persistent or worsening pain, new numbness or tingling, weakness, headaches, or functional decline. The provider may review MRI results, adjust medications, order additional imaging, refer to a specialist, or change the treatment plan. The documentation must show active medical management and moderate complexity. If the note only says the patient is improving and should continue the same treatment, that usually does not support a 99214. Coding correctly decreases audit risk around unsupported 99214 billing. A 99215 is a high-complexity established patient visit. This code should be used carefully and only when the documentation supports high-level medical decision-making. Examples may include significant neurological deterioration, severe symptoms requiring urgent escalation, complex imaging and record review, high-risk medication or treatment decisions, or extensive coordination with specialists. A 99215 should not be used simply because a patient has been in pain for a long time. The complexity and risk must be clear in the chart. Let's compare 99203 and 99204. A 99203 may involve a new patient with uncomplicated neck or back strain, mild to moderate pain, basic exam findings, and a conservative treatment plan. A 99204 may involve a new patient with multiple injured regions, persistent or worsening symptoms, radicular complaints, headaches, imaging review, prescription management, or referral. The difference is not just how many complaints the patient has. The difference is the complexity of the problems, the amount of data reviewed, and the level of risk involved in management. The difference between 99213 and 99214 is especially important. A 99213 is typically a stable or improving follow-up visit with low complexity decision-making. A 99214 requires moderate complexity. That may include worsening symptoms, new neurological findings, prescription medication management, imaging review, treatment escalation, or specialist referral. A helpful question is, did this visit require a meaningful treatment decision beyond simply continuing the same plan? If yes, and the documentation supports moderate complexity, 99214 may be appropriate. If not, 99213 may be more appropriate.
Now let's apply these concepts to real-life auto accident scenarios. These examples are not intended to criticize any individual provider or billing decision. They are intended to help us think through whether the documentation supports the code selected. As providers, we want to make sure the level billed reflects the actual complexity of the encounter, the decisions made, and the risk managed. The key question is not, what code do we usually bill? The question is, what does this note actually support?
Here is an example of a visit that may be overcoded if the documentation is limited. A 19-year-old healthy, established patient presents for a short follow-up visit, approximately 5 minutes, with neck pain, mid or upper back pain, and lower back pain. There are no other complaints, no neurological findings, no imaging review, no referral, and no significant change in treatment. A topical pain medication is prescribed. Even though the patient has pain in more than one area, that alone does not automatically support a 99214. For 99214, we need to see moderate complexity. That may include worsening symptoms, neurological concerns, imaging review, medication management with meaningful risk, treatment escalation, or referral. Is this a low or moderate complexity visit? Based on the information described, this would generally not support a 99214 unless the note includes additional moderate complexity MDM or the provider meets the required time threshold for that code. A 99214 is an established patient visit that generally requires moderate medical decision-making or the applicable total provider time threshold. In this scenario, the patient is young, healthy, has musculoskeletal pain complaints, no documented comorbidities, no neurological symptoms, no imaging review, no diagnostic escalation, no specialist referral, and no significant medication management beyond a topical pain medication. The fact that the patient has pain in multiple spinal regions does not automatically make the visit moderate complexity. The teaching point is simple. Multiple pain complaints do not equal moderate MDM unless the documentation shows why the decision-making was moderate. Here is an example that may support a 99214. An established patient presents after an auto accident with worsening headaches, intermittent blurry vision, ringing in the ears, and concern for post-concussion symptoms. The patient is also hypertensive, has a history of heart disease, is on blood thinners, and has not been taking blood pressure medication due to a transition in primary care. The provider identifies that pressure wave therapy may not be appropriate while the patient is on blood thinners and contacts the chiropractic physician to hold that therapy. The provider orders MRI imaging, refers the patient to neurology, sends an interim blood pressure medication dose, and shortens the follow-up interval to 1 week. This is very different from a routine pain follow-up. Here, the provider is managing multiple concerns, recognizing a therapy safety issue, addressing uncontrolled blood pressure, ordering imaging, referring to neurology, and changing the follow-up plan based on risk. The patient is not presenting with simple neck or back pain alone. The provider is addressing worsening headaches, possible post-concussion symptoms, intermittent visual symptoms, tinnitus, hypertension, cardiovascular history, blood thinner use, and a safety issue involving pressure wave therapy. MRI imaging is ordered because symptoms are increasing in intensity and frequency. Referral to neurology is made. Risk is meaningfully higher because therapy that may be inappropriate or contraindicated. This is active medical management, not routine conservative follow-up. When comparing 99203 and 99204 for a new patient, the key difference is complexity. A new patient with neck and low back pain, no neurological symptoms, no red flags, no imaging review, and a conservative care plan may support 99203. But if that new patient also has headaches, radicular symptoms, intermittent numbness or tingling, imaging review, medication management, or referral, the visit may move into 99204 territory. The difference is not just the number of pain complaints. The difference is whether the provider is managing a more complex presentation with more data, more risk, or more treatment decisions. Pediatric cases require careful documentation because the provider is often counseling the guardian and making school or activity recommendations. For example, a child with only neck and lower back pain, no headaches, no neurological symptoms, and conservative care may support a lower complexity visit, such as 99203 for a new patient or 99213 for an established patient. But if the child presents with headaches, neck pain, lower back pain, knee pain, and requires school activity restrictions, the provider needs to document the clinical rationale clearly. The school letter alone does not automatically make the visit moderate complexity. The question is why the restrictions were medically necessary and if there are additional risk factors, functional limitations, or concerning symptoms. The difference between 99213 and 99214 often comes down to whether the visit is routine or whether it required meaningful, active management. If the patient is improving, there are no new symptoms, and the plan is simply continued, 99213 is often more appropriate. If the patient is worsening, has new neurological symptoms, requires imaging review, medication changes, referral, or escalation, then 99214 may be supported. This is why the note must clearly explain what changed and what decisions were made. For new patients, 99205 should be reserved for truly high-complexity encounters. A patient with neck pain, back pain, headaches, radicular symptoms, imaging review, and medication management may support 99204. But 99205 requires more. For example, severe worsening headaches, confusion, vomiting, new weakness, visual disturbance, anticoagulant use, complex imaging review, and urgent referral or emergency evaluation may support high complexity. The difference between 99204 and 99205 is not simply that the patient has more complaints. The difference is the level of risk, the seriousness of the differential, the complexity of the data, and the urgency of the management decisions. The biggest lesson from these case studies is that the code must be supported by the documentation. A patient can have pain in several areas and still be low complexity if the conditions are uncomplicated and the plan is conservative. On the other hand, A patient with comorbidities, medication risks, worsening neurological symptoms, imaging orders, referrals, and treatment changes may support moderate complexity. The provider's job is not only to treat the patient, but also to document the clinical reasoning behind the treatment decisions. That is what supports accurate coding. For auto accident EM visits, documentation should clearly explain the medical necessity of the visit. At a minimum, the chart should include the accident mechanism, symptoms, injured body regions, functional limitations, relevant exam findings, diagnostic data reviewed or ordered, treatment decisions, medication management, referrals, and the clinical rationale for the plan. For moderate and high-level visits, vague documentation is not enough. Instead of only writing MRI reviewed, document what the MRI showed and how it affected the plan. Instead of only writing medication prescribed, document why the medication was needed and any relevant instructions or risks discussed. E&M codes may also be selected based on total provider time on the date of service. This may include time spent reviewing records, seeing the patient, counseling, ordering tests, coordinating care, documenting, or communicating with other healthcare professionals. Do not count staff time. Do not count time spent performing separately billable procedures. If billing based on time, document the total time and what the time included. For example, total time spent on the date of service was 47 minutes, including review of ER records and MRI report, face-to-face evaluation, treatment counseling, medication management, and documentation. Note, documentation time is only counted for the day of service, so next day notes will not account for time in the previous day. Common coding mistakes include billing every follow-up as a 99214, using cloned documentation, failing to show medical necessity, or documenting symptoms without explaining clinical decision-making. Another common issue is vague data review. For example, writing records reviewed is weaker than identifying which records were reviewed and how they impacted care. The documentation should tell the story of the visit and support the level billed. To summarize, 99201 is no longer billable. New patient visits use 99202 through 99205. Established patient visits use 99211 through 99215. Select the level using medical decision-making or total provider time. For MDM, remember the three elements: problems, data, and risk. Most importantly, the code should match the complexity of the encounter and the documentation in the chart. Accurate documentation supports accurate billing.
This training is intended for educational purposes only. It does not replace current CPT, CMS, payer-specific, state-specific, legal, or organizational compliance guidance. Providers are responsible for ensuring that all billed services are medically necessary, accurately coded, and properly documented. Please contact the medical director, Dr. Bronner, for any remaining questions or concerns. Thank you for completing this training.